chairing one of the final sessions here on improving maternal care at the forum. We have 4 fantastic speakers today, and we'll be taking a 10-minute presentation followed by 5 minutes of questions, and I'd ask you just to hold off your questions until the end of the presentation, if that's okay. I'd also, just before we start, like to say that this session is being streamed live across the world. I'd like to just welcome all our virtual delegates and international participants who couldn't be here to this session. And to those of you that are going to be watching this on demand, welcome to Amsterdam. I'd like to kick off with our first presentation. And this is Edward Broughton, and he's from the United States. He's going to be telling us about cost-effectiveness study in the Niger Maternal and Newborn Care Collaborative. Thank you, Edward.
Hi, thank you very much. And hello, world. It's a pleasure to be here, and thank you all for showing up. So today what we are going to be talking about, or what I'm going to be talking about, and you're going to be listening to, is a discussion about the maternal and neonatal health collaborative that was conducted in Niger between 2006 and 2008. So we're going to be talking about this study that was a cost-effectiveness study. Basically, what questions did we ask? I'm going to outline the intervention, and then we're going to discuss the results, talk about the limitations, not that there were any limitations because it's a study that I did, and then we're going to be talking about what's next in line. And just to start with, I just want to clarify the division of labor for this particular study. I did the research, and Dr. Maina Bukar is the one who actually did all of the work in terms of the collaborative itself. I am not an improver myself. I've never improved anything. Dr. Bukar and the Niger team are the ones who really did excellent work in Niger. They really worked very hard to pull this all together with the help of some international consultants, etc. So they're the ones who should be taking the credit for any of this work. Okay, so what was the intervention? It was basically a collaborative that worked on improving maternal and neonatal outcomes. One of the most important things they did was implement active management of third stage labor, or AMSTEL, as we like to call it. They also implemented changes to improve newborn care, essential newborn care, and it was a collaborative, as I've said, among 33 facilities throughout Niger in 7 of the 8 what do you call them? Regions, and it was in partnership with the Ministry of Health. So USA doesn't really pay for any implementation at the patient level. So they don't pay for the drugs, they don't pay for any equipment at the facilities. They just pay for the labor that goes into implementing the collaborative improvement itself. It went over the 2 years, as I said, and during those 2 years, 89,000 deliveries were attended in the facilities that were part of the collaborative. Okay, and so the question that we were asking was not, is it cost effective to allow mothers and babies to die? Although this is a very important philosophical question that unfortunately we don't have too much time to talk about. But really one of the things that I think has been missing a lot in some of the discussions that have been had at the forum so far is really what it means to be cost effective. And really I don't think, we don't have time to delve too much into it now. But for this study, you should, and for any cost effectiveness study, you should really be thinking about cost effective compared to what. And in this case, we were just saying that we're going to look at the cost effectiveness of the implementation of the improvement collaborative compared to doing nothing at all. So compared to the business as usual scenario in Niger at the time. And we're going to be looking at it, or we did look at it, from the perspective of the funders and separately from the perspective of the Ministry of Health by itself, if it was to implement the collaborative by itself. Before the intervention, the statistics for maternal and newborn care, newborn health in Niger were absolutely terrible. So 1 in 7 women died in childbirth in 2005. That's the lifetime risk. It's also the fertility rates are very high in Niger. It's up around 6.5 in that period. And the rates of post-partum haemorrhage are very high, and that's the leading cause of maternal death. So, Dr. Bukar and his team did the improvement collaborative. It started in June of 2006 with a learning session, and then there were coaching sessions afterwards, then another learning session, I think 4 months later, etc., over the 2 years. And you can see from this graph, on the x-axis we have time, and you can see that when it was implemented in 2006, there was a significant increase in the blue line, which is the proportion of patients who were treated to compliance with Amstel norms. And concurrent with that, at about the same time, there was a significant decrease in the rates of postpartum hemorrhage in the group of the mothers who were in those facilities. Okay, so what's this? It's the elephant in the room. And the elephant in the room with this kind of thing is attributability. So we did this implementation, and we saw significant improvements in the rates of women receiving treatment compliant to the norms. But who's to say that it was the program, our program, or Dr. Bukar and his team's program, that actually did it? And a lot of other things happened in Niger at the time. And we didn't have a control group. So for those of you who are cynical and critical of these kind of studies, I mean, you might be wondering if the improvements that we saw were actually, we could attribute it to what we did. And even if you could say that, was it specifically attributable to the kind of collaborative that we did? I mean, if we just went there and taught them songs or how to dance or something, I mean, would they have improved just as much or more or less? So this is one of the big questions in this kind of thing, and I'm sorry that I didn't have a control group in this study. But what did we find with the costs? Before the implementation, a Nigerian woman going for a delivery, it cost $35 per normal delivery. At the end of the collaborative, it was down to $28. So why the decrease? It was because there was improved outcomes, so fewer cases of postpartum hemorrhage and fewer other adverse outcomes, and so it's cheaper because there are fewer cases that are expensive to treat. The USAID project, the Healthcare Improvement Project, spent $2.12 per patient to develop the program. So that's 89,000 multiplied by about $2 is $188,000. And so that's what they spent just developing the program. So this is the cost of foreign or some of the consultants from DC coming over to meet with the Ministry of Health and put this program in place. It's for the meetings, it's for the flights and all of those kind of things. During the collaborative itself, so this is the cost of having the meetings, the learning sessions, so getting all of the clinicians from those 33 facilities into Niamey to have the learning session, and then paying for the coaches on a monthly basis going out to do the coaching sessions. It all ended up being $6.53 per patient, which is overall, with that and the development costs, USAID spent about $800,000 on this project for 89,000 women. And so the additional cost, so this is the cost on top of what it used to cost for care for these women. The additional cost when USAID did the implementation was $2.45 per person. Now, if we assume that the Ministry of Health of Niger could do the same implementation, then the cost, they wouldn't have to redo the development cost because that's already been paid for by USAID. So they don't have to redevelop the program because it's already there. But they have to go and do the learning sessions, they have to go and do the coaching visits, etc. And that's going to cost, we assume, about $4.60 or $4.58. And so that's an additional cost per patient of minus $1.67. So basically it's cheaper for the Ministry of Health because they're paying the $28 per birth anyway. So it's actually cheaper for them to implement this program. Births will be cheaper for the Ministry of Health. Okay, so the incremental cost effectiveness ratio is the metric by which health economists use to measure and to compare, to do cost effectiveness analysis basically. And what you want is, if it's a positive number, you want it to be as close to zero as possible. And I did this analysis based on DALY, so that's disability adjusted life years. It's just a composite measure for well-being in a way. Let's just leave it at that. So $2.86 per disability-adjusted life year. So how does that compare to other programs in Niger? Well, with this, you could go to the Ministry of Health and say, you know, this is how much it costs. How much does it cost for a malaria program? Or how much does it cost per DALI for an improvement collaborative to work on preeclampsia or something else? You've got something tangible that you can compare this program with to something else. With all of the flaws in the measurement of this, at least it's a start. At least you've got something tangible that you can use for decision makers, data for decision makers. And for if we assume that the Ministry of Health did the implementation, then they would actually save money and improve health outcomes. So we say that strategy is dominant. It means that you're crazy not to do it because you're saving money and you're improving health. So it's a win-win situation. Okay, so believe it or not, there were some weaknesses in this program or this evaluation. One of the issues was the attributability. Like I said, with no control program, critics are going to say, well, you know, it could have been for any other reason. You know, the GDP of Niger went up over that time, so who's to say that it wasn't that? And there were other issues as well going on. But we did have a look at those to see if there were other implementations that were going on at the time of this implementation by USAID, and there wasn't anything else happening. You know, we're not strictly looking for causality in the same way that an epidemiologist would. I mean, we're not looking at Hill's 9 or 10, whatever it is, causal criteria to be fulfilled. But, you know, we've got a few of them here. We've got, you know, some case for attributability, but it's not a strong case, and it would be much better if we had a control group. And also we're assuming that the Ministry of Health can do the intervention, which reminds me of a little joke about economists. So an economist and his friend, well, actually you have to suspend disbelief because economists don't have friends, but taking that into account, an economist and their friend were walking down the street, and the friend sees a 10-euro note on the ground and bends over to pick it up. And the economist grabs him and says, "Don't pick that up. If it was worth something, someone would have picked it up already." And what I mean by this is that you know, if the Ministry of Health knew that it was that it was going to save money by this, it would have done it already. So who's to say that us doing this is going to empower the Ministry of Health to do this by itself? And this is one of the other things that we need to look at. It just so happens that the Ministry of Health has actually implemented some of this in other areas. We haven't really looked to see how effective it's been in those areas, but it is something that has actually happened. We didn't include newborn outcomes. Why did we not include newborn outcomes? I don't know. It's I don't like babies. I guess that's why. No, it's because we didn't really take very good measurements of. I don't really dislike babies, but yeah, we just didn't take very good measures of outcomes for newborns. But if we were to add that into the equation and consider the DALIs associated with that, the program would have looked even more cost effective. So this is a pretty conservative result that we've got. And you know, some of the cost data was questionable because we were looking at it retrospectively. The HCI data on cost was very good because USAID has strict rules about their accounting, but the Ministry of Health doesn't really track the costs of deliveries that closely. So that was another issue. So what are we doing next? We're trying to publish it, but we still have a long way to go, and you can see the last one there is the Grim Reaper, so hopefully it'll happen before I die, but we've submitted it for publication. And yes, that's it, I guess. Thank you very much for coming. And I was talking about cost effectiveness. You've all done a cost effectiveness analysis yourself in coming here, and the opportunity cost was you could have gone to the Van Gogh Museum or any of the other great museums in Amsterdam, or you could have enjoyed the pleasures of the flesh. But I appreciate the fact that you saw this, coming to this, as much more valuable to you than doing those things. So I appreciate that very much. Okay, so are there any questions? How are we doing?
I'll be coming round. Thank you, Edward. I'll be coming round with the microphone. Have we got any questions at all?
Yes.
I have this feeling that this week I'm getting an education in how to use humor effectively in scientific meetings. Could you go back to the slide with the cost benefit, that little timeline?
Yes. Not this one.
No, the timeline.
The timeline.
Yeah. Okay. Yep. So I didn't quite understand how there's a pre and there's a post, and then there's a cost associated with it. I didn't. In this way of doing it, I mean, you're going on assuming that you can retain this benefits forever and ever and ever.
Yeah.
Don't you then spread the costs more over more deliveries?
Exactly. Yes, you do. And that's based on the assumption that those improvements are going to continue on.
So how many costs? So how many deliveries did you spread the intervention costs over now? Just the.
Right, so we just spread it over the deliveries that were attended in those 33 facilities over those 2 years. So there was the 89,000. So yeah, you're absolutely right. After June 2008, there were more patients who were being seen, and one would hope, although we didn't measure, well, actually we did measure it, but that's another story. One would hope those improvements would be maintained, and so you would actually be increasing the denominator for those costs. So yeah, that's a good point. And so as I said, this is a conservative estimate if you look at it that way. Of course, the other issue with that is that we're attributing 100% of the change that we saw to our program, and we are on a little shaky ground when we do that.
Thank you.
Edward, I've often looked at the Niger graph and wished that two things. One is that we had a longer baseline so that we could have seen something more of the variation in performance prior to intervention. But also, and this is still something I don't understand, is it's not annotated. And if we had annotated it both with the key interventions within this project, but also any other key interventions, as you say, external to the project, that whilst it wouldn't have helped us necessarily in determining sort of attribution, at least it would have increased our degree of belief and confidence that the results were likely to have been due to the intervention.
Yes, yeah, you're absolutely right. Yeah.
Thank you. I'm going to have to call it time on the questions, I'm afraid, and move on. Thank you very much, Edward. Next we have Caroline Keown. Caroline will be talking about the introduction of a universal CTG tool at her hospital trust.
Good afternoon, everybody. My name is Caroline Keown, and I work as a midwifery manager in Northern Ireland in one of the healthcare trusts within Northern Ireland. And this afternoon I wish to share with you the experience we had in introducing a tool to facilitate the interpretation of fetal heart rate tracings, also known as CTG tracings, and the mechanisms we as a team put in place to monitor compliance with this tool. Start with, I'll give you a little bit of background as to where our trust sits. This is the geographical spread of our trust, quite a rural community. My trust employs approximately 12,000 staff as an integrated health and social care trust. It services quite a large population in UK terms, and the trust was also a member of the SPN and the SPI too. The maternity services has a birth rate of about 4,500 per annum, 2 hospital sites, both consultant-led, and approximately 250 community and hospital-based midwife, and that is supported by the multidisciplinary team. Background is that fetal and maternal surveillance within maternity care is an integral part of the care that you provide. Practice known as cardiotogography, CTG tracings, is quite widespread, but because it's open to human interpretation, it's open to error, and has always been one of those more controversial practices, even though it is very widespread. Our trust had a couple of quite high-profile cases which had been reported very widely in local and regional media. In one of the cases, the interpretation of CTG tracings had been questioned and was found to have a direct effect on all the subsequent care that had been planned. Unfortunately, the care resulted in a baby dying, and as a result of the trace being incorrectly interpreted as normal, unfortunately, the baby died. The Trust reviewed its standards and guidance as a result of this case, as would be usual practice, and following the publication of standard guidelines, the Trust policy was reviewed quite extensively. But we were still left with the problem of how we were going to ensure our practitioners on the floor were going to grade and record the findings of CTG tracings. So we had a few issues to address. We needed to develop a tool to assist practitioners when interpreting CTG tracings. We need to ensure that it was best practice when reporting CTG findings, particularly to our medical colleagues, and ensure best practice when recording CTG findings, because as we all know, if it's not written, it didn't happen. So what did we do? We came together, we tried to get the key players within a room. We did the usual brainstorming, and we decided that we needed to develop a tool that could be used as a part of our case notes. And we decided then that we would involve the Trust Patient Safety Manager and go down a quality improvement plan route. So we trained a couple of key people in the IHI methodology. We identified champions in each of the clinical areas, and we established a working group with representatives of all the key disciplines. And in the initial stages, this working group met initially fortnightly and then on a monthly basis while we were getting this project up and running. The work commenced in January 2009. We trained all the clinical staff on the ground, and then we also set up a system of monthly lunchtime sessions to address any problems that staff were coming up with on the ground, to review some of the more difficult tracings and try to share as much learning as possible. The Trust also had revised our policy at this stage, and we used the training as a platform to highlight the changes in the policy to all the staff on the ground. And this is the latest incarnation of our tool. It comes in a sticker form, it comes in a roll. There's about 1,000 stickers in each roll, and we place them in all of our labour wards and assessment areas. And what we ask the staff to do is, on an hourly basis, take one of these stickers and literally circle or tick each of the parameters. And in grading the CTG, then it should take you down to either normal, suspicious or pathological, which then leads you on to whatever actions. We've had a couple of versions of the CTG sticker, but this latest one seems to be has been evaluated very well, and the staff seem to find it the easiest to use. So how did we evaluate? We set up a system of monthly audit through the champions in each of the clinical areas. 10 case notes were randomly selected. And we used the NICE guidance, which outlined the parameters of record keeping regarding CTG tracings, and we devised an audit tool around this. So we devised a reporting system, and we decided to display our findings in a dashboard style. And this is displayed on a monthly basis. It's available beside all of our whiteboards in our clinical areas for staff to see. And it gives a very visual representation of where our audit findings are on a monthly basis. Our aims were to have 95% of compliance with all elements of the audit measures. We wanted to create a culture within the clinical environment that encouraged use of this tool, but to also encourage universal approach to interpreting CTGs. And we wanted to continue to embrace the patient safety culture, but also the thing of trying to have real-time feedback to staff, because as we all know, there's no point in talking to staff 6 months after the event has happened. Our challenges have been many. It's not all been plain sailing. And as we've heard, maybe with themes of many of the conference presentations, it has been about sustainability. It's about keeping the energy within the team, keeping new staff that come on board trained in all the aspects, particularly staff maybe who haven't been on the journey that some of the more established staff have been on. And also ensuring that all disciplines are using the same methods of interpretation. Our successes really have been that the tool has been fairly widely adopted and embraced in the clinical areas across the Trust. We are now part of a perinatal collaborative programme in Northern Ireland, and due to the lessons that we have learned in introducing this tool has now been adopted on a regional basis and is going to be used in all maternity sites across Northern Ireland, and we're very proud of that. It has also helped to raise the profile of the IHI methodology within the unit as well, and certainly the staff are more aware of the components of that. What's our next steps? Really, the tool that we've developed is for intrapartum assessment, so we're looking now at an antenatal CTG assessment tool. We also need to continue, as you could have seen by our dashboard, it wasn't all green, so we need to continue to monitor compliance and focus on areas of poor compliance, and also spread then into new areas and identify new areas of work. So the lessons we have learned as a team is the importance of staff engagement, importance of real-time audit as well, and it's about sustained improvement, not just always about audit findings and results. Thank you, everybody, for your attention.
Thank you, Caroline. Very interesting. Can I take questions from the floor, please?
Thanks very much. That's very interesting. This was driven originally by an instance of, or a number of clinical incidents. Mm-hmm. Have you measured a reduction in clinical incidents as a result of implementing this?
We have, around the time, our trust was very extensively reviewed at the time, and we were the subject of an independent inquiry, so there was a number of recommendations made at that time, and we were able to get together the funding for a governance midwife, a risk assessment midwife. So she has developed the obstetric dashboard within their unit as well, where we're measuring a number of obstetric outcomes on a monthly basis. So we've piloted that through the first part of 2010, and we're just at the process of evaluating that now. And one of the outcomes or one of the measures that we measure on a monthly basis is the number of clinical incident reports that are generated. We have a trigger tool, which would be common in most of the maternity units. It's based on the RCOG work that has been done, but one of our measures that we do is unexpected admissions of term babies to the neonatal unit, or babies whose cord pHs measure less than 7.05. So we do a review on a monthly basis of those cases anyway, and that is reported through our labour ward forum. So we're only really at the point, probably, and we hope within this year, to be able to produce data that actually supports the work that we've done and shows that there's been long-term improvement.
Thank you. Any further questions? Thank you. We'll move on. I should say that if you'd like a copy of Caroline's presentation, it's available just by the door to collect. Next we have Elie Azria from Paris. Elie will be talking about a study in the Northern Paris Community Perinatal Network.
First, I would like to apologize for my very poor English and for my very bad accent. I'm sorry about that. So I'm a gynecologist obstetrician. I'm working in a hospital in Paris called Bichat Claude Bernard Hospital. And I'm going to present you a program and the assessment of this program that was designed to improve early prenatal care. Early prenatal follow-up is for us a very important stake. It's very, and we are very concerned about the improvement of this early prenatal care, because this early prenatal care can help to decrease maternal and perinatal mortality and morbidity. This can be achieved through the decrease through the risk assessment, early risk assessment, and the adaptation of prenatal follow-up, but also through pregnancy adaptation, which allow a better growth surveillance and the prevention of post-term complications. It also helps to make early diagnosis of multiple pregnancies, which helps to determine early chorionicity and adapt again the follow-up, and also to screen for fetal abnormalities. The place we developed the program I'm going to describe is characterized by very special population and characteristic. First, there is a very high natality rate, one of the most important in the Parisian area, a shortage of specialized physicians, and very high prevalence of social deprivation. For instance, in 2001, in Bichat-Claude Bernard maternity unit, 50% of the women have been seen by a social worker, 22% did not have any health insurance, nearly one quarter were very isolated and had no residency permit, and 6% were hosted by emergency social services. This situation are known to increase the risk of inadequate follow-up and also to increase the risk of mortality and morbidity for both the mother and the newborn. Facing this situation, one of our aims was to improve this early prenatal care and to improve the access to this early prenatal care. And for that, we created a community-based perinatal network. Objective was so to promote early initiation of prenatal care, and with priority objective that were first prenatal visit within the first 12 weeks of pregnancy, a first ultrasound examination between 11 and 14 weeks, and to improve the quality of this first ultrasound examination. This network was based on the voluntary partnership between private and public caregivers, and the caregivers signed a commitment chart, a commitment to use all the communication channel developed by the network, which mean fast-track pathway to find prenatal examination for women, and commitment to follow the continuous medical teaching program, which was at least 4 annual thematic sessions. The professionals involved in this network were in the hospital mostly obstetricians, midwives, biologists, social workers, and psychologists. And in the private sector, they were general practitioners mainly, few obstetricians, ultrasonographers, midwives, and biologists. To assess this program, we conducted a retrospective study on medical records over 4 different periods. 1 year before the network implementation, 2003 was the year the network was set up, and 2004, 2008, 1 and 5 years after the network implementations. The endpoints we chose were proportion of women with first ultrasound screening performed, and the proportion of nuchal translucency measurements deemed acceptable. To assess the quality of the nuchal translucency measurement, we chose a criteria based on the Hermann image scoring, which is a validated tool to assess the quality of this measure. And this score is composed by 6 items, 3 items on 2 points, and 3 items on 1 point, so that the maximal score for one measure is 9 points. On this slide, you can see a summary of our findings. First, the first trimester ultrasound screening performed, as you can see on this slide, this from a rate of about 55%, we reach 1 year after the implementation of the network, a rate of nearly 72%, and 5 years later, the same rate remains. Here you can see the assessment of the quality of nuchal measurement. Measure of unacceptable quality decreased over time from 28% to 9%, and reasonable or excellent measure rise from a proportion of 51 to 77% in 2004. When we compare 2004 and 2008 periods, the rates of reasonable or excellent measure were not statistically different. So, a few comments now on this program and on these results. First, about the relevancy of the chosen endpoints. First trimester ultrasound screening is, of course, not a perfect reflection of the whole prenatal care, but as it is associated with reduction of perinatal risk, it is, according to us, still a quite good indicator. The quality of nuchal translucency measurement is, of course, questionable, as it is not systematic care, but because of the possibility to have a very simple and validated tool with a standardized measure, it is that was quite obvious for us to use this kind of indicator. According to the attributability of this result to our intervention, we were not aware of other intervention during the same period, and we decided to stop our evaluation in 2008 and not in 2010 because there were changes in the procedure between this after 2008. Now, about the 5-year results. As you can see, we can interpret that as a stabilization related to the effect of our network, which is quite encouraging. But we can also see that as a stagnation. And this stagnation maybe point out the limit of this intervention and show that maybe we failed to reach the more socially deprived women, and which is, of course, a very important limitation for us. So this, to conclude, lead us to think that this kind of intervention of involving professionals is essential, but have to be associated with upstream intervention and social policies. I thank you for your attention.
Thank you, Elie. I must say your English is perfect and you're perfectly understandable. I couldn't have given a presentation in French, so thank you. Do we have any questions from the floor, please? Thank you.
Hi, thanks. I work in Russia, and I think that it's clear that the poor health outcomes and the maternal and deaths, and to some extent the fetal losses in the system in Russia, are attributable to this socially vulnerable group of women. So I think it's a very similar group that you're talking about. So I think it's very important to get them into care. But I'd like to hear more about Not just, you created the network, but what exactly did the network do? What were how did they get those women into care?
One of the characteristics of the area is that many women are not able to find a place to deliver, and most of them do not speak perfect French, and when they present at a desk, they could be easily sent out, which is very problematic. And by creating this network, each time a woman comes to one of the office of the caregivers, either private or public hospital, this one is responsible to take his phone and try to find a place for her to be and manage to find the appointment at the right time. So this is one of the most important facts, which is not very complicated, but in everyday practice it's not as simple. And the other point is to teaching programs. We wanted to have all our community of practitioners to have a teaching program and to participate to this teaching program.
Thank you. Any further questions from the floor? Thank you. Thank you, Elie. Okay, and our final speaker this afternoon is Lizzie Saka. Lizzie is from Malawi, and she's going to be talking about post-partum haemorrhage PPH prevention protocol in Malawi.
I'm Lizzie Saka from Malawi, and I'll be talking about the use of a post-partum haemorrhage prevention protocol. I should say that there is something. Okay, so Malawi is located in the central part of Africa, and we are bordered by Tanzania, Zambia, and Mozambique. We are a very small country, as you can see, but as a program, Maikanda, we've been working in 3 districts which are circled in blue. That's Salima, Kasungu, and Lilongwe. And to the right there is what we've been doing up to date. We are in the spread period, but that's not very important as of now. Okay, so the problem that we're having is, as we did the analysis in 2007 of the deaths of the mothers that were dying, most of the mothers were dying due to PPH, which is the block at the far beginning to your left. About 43 mothers died out of 101 mothers died of PPH, which was very alarming, and we had some problems with blood. We've got a system where blood is supposed to come from there's an agreement between the government and the blood transfusion service, but they were not able to meet the big demand that was there. So most of the mothers that needed blood could not get it. And as a result, we started thinking that maybe instead of waiting for everyone to develop PPH after they've delivered, we should try to prevent this. So this is what we did. There was a team that had piloted using a prevention protocol and seeing how it's going to be effective if they applied it on non-risk women, like previous scars and some that had history of hemorrhaging before. And so we found that for this particular hospital, it had worked very well. And in 2009, April, we decided that everyone in the collaborative of 11 hospitals should be using this prevention protocol so that not many women develop PPH at the end of the day. So on admission, each of the women, the first thing, the key to this prevention protocol was identification. And on admission, every woman who works in the labor ward was supposed to be identified by putting a red sticker on their file, and then they were catheterized and when they went in labor, active management of first stage of labor was practiced. And then the crucial period is after delivery. Not many women were also being monitored, but this was demanding them that they monitor the women every 15 minutes for at least 1 hour before they discharge them to the postnatal ward. So this is the protocol that has been that has been used for all these since 2009 to date. And I tried to look at what has happened so far. So this is a picture of some of the seven hospitals that had used this protocol. Where you see a star is when the protocol was introduced. We were not able to get very good data before we started the intervention because the system did not provide a way of capturing the postpartum hemorrhage and separating it from the antepartum, the pre and post hemorrhage very well. So you may be thinking that before you started the intervention, actually the performance was very good, but it wasn't because the data there is a bit questionable. And so what we're trying to do is we wanted the blue line to be going towards 0, and we also want the red line to be flat at 0, whereas the green line should be going towards 100%. That is what we want to do. So far, this in the picture of the seven hospitals, this slide goes up to the time that I was submitting the abstract. The picture was very good, as you can see. At the beginning, we were operating at around 2.1 median. That's where the performance was. But we are since we started protocol, at least since September, we are. If we to revise the median, we'll be operating at around 1.2%, which is a very significant reduction in the incidences of the PPH. And this is another hospital that's been using the protocol. This hospital, in spite of starting instead of starting the protocol use in April, this team had a bit of a challenge and they started late. But once they started, as you can see, their performance on the incidences, their incidences were a bit high. But once they started getting into using the protocol very well, they are not at 100%, but at least around 78%, their incidences have gone down. We are below the median. And their dates, as you can see, the red line is very flat. And on the bottom of the slide is some of the things that they tried to do. Use the protocol. They started using the protocol late, even if they came to the collaborative session in April 09. And they did not start very actively until August. But their performance has stabilized since then. So this is also an example of another team that's working on the use of the prevention protocol. The attention for this one is, if you can see, their line is starting from, when we just starting, they were around 40% use of the adherence to the protocol. But as they gained confidence in using the protocol, it steadily increased. Like their adherence got very good. And you can see this is the highest, one of the teams that they had a highest incidence of PPH, but it drastically reduced from 3.26 to around 0.8, which is a significant improvement. And even if they had a drop at some point, as you can see to your far right, the incidences have not been affected that much. So this has got a big impact as well on the overall results. We can see that now, instead of PPH being the first on the line, this is just a sample, but we've also done a recent sample and the picture is not changing. We've seen that PPH now has ceased to be the highest killer, to be the first cause of deaths. There's been another one that has taken first step. So I'll just quickly go to the first slide, which I showed, which was on the causes. As you can see, before we started, there was a very, very big difference. So the second cause of deaths has now become the first cause of deaths, and the first is gone to the third, as it is indicated there. So we've learned so much since we started doing this work. We've known now that if we use this protocol very well, if we get our adherence up, we'll be reducing incidences. And it's one of the most effective ways of, instead of going into the treatment, you can do the prevention, and you get a very good impact, you get a very good reduction. And we've also learned that in doing this kind of work, because we had to do a lot of preparatory, it's important that we should do a lot of preparatory work, especially because it had to use a lot of resources in terms of IV cannulas. And in some of the places, their adherence was affected because they had to replenish the supplies like very frequently, and it had very big cost implications. And we also think that in resource-poor settings, instead of doing everything, you have to target your efforts very well. If you can do a QI effort on what you think is your problem that's really bothering you, not to do everything. Like they could have done maybe they could have done eclampsia, but this wasn't what was bothering them. What was their best, or what was the biggest problem was PPH. And if you target where the high leverage point is, you'd get a very high impact. And we also think that after doing all this work, and as I said in the beginning, that data was not very easy to come by, and if we are to direct efforts for research in the hospitals in poor resource setting, we'll have to have data that is very good, that is helping to focus the teams. So in doing all this work, this is what we've learned. Thank you for your attention.
Thank you, Lizzie. Do we have any questions from the floor, please?
Thank you very much. Robert Chiakalila, I work in Uganda for URC. Compliments on your presentation. I think it's really good. When you look at what you looked at in 2007 and the list of people, the list of causes of deaths, and PPH was really high. I'm glad to see that it's going down. But are there efforts, or have you tried using the same quality improvement approaches to address the other areas that are now, leading causes of maternal deaths? And how have you done that?
Okay. So what we do, we do these collaborative sessions like every other 4 months, and before we go into the beginning of session 1, we always look at what is the recent problem. And because of the lessons that we learned from this one, this year we're working on the first 3 causes, except anemia because it starts from afar. But we're working on preeclampsia and eclampsia because when we add them, we are coming towards 5. And we are working on puerperal sepsis. We are doing prevention and treatment of puerperal sepsis. So for puerperal sepsis, we are also doing the same to identify all the known risks. And then for those that develop puerperal sepsis, we are treating them. And we are also working on eclampsia, and we're working on PPH. So what we've done is to work on the those causes that are contributing 80% of the maternal deaths. So should it happen that we come here or someplace next year, I would invite you that you should come, because I'll be presenting what has happened so far. Yeah.
Thank you. Do we have any other questions from the floor?
Yeah, I think it's great that you're addressing the highest cause of maternal death, but I had some questions about the data. First of all, this is a 4-month period?
Yeah.
So do you have, I can't easily add it up in my head and figure out whether the number of overall maternal deaths has decreased.
Yes, the number of the overall maternal deaths have decreased. And I did not have that slide here, but we've seen a decrease in the number of maternal deaths, especially from PPH.
Yeah, I think that would be the most convincing. Also, I wanted to understand about the high-risk group, how it was identified, and whether and what % of the actual cases of hemorrhage occurred among the high-risk group.
There was like a criteria that was developed for all the non-risk. For maybe some of my gynecological friends would help me, but there was a group that were saying everyone in this group this has to be done for them. And for what was the next part of the question?
So the question is, you have a group that's been identified as high risk over here, right?
Yes.
And they occupy some percentage of your moms?
Yeah.
20%, 5%? Small number, big number?
When we started doing this project, we're not looking at it from looking, even if we're working on a section, we were seeking to have an impact on the overall population. But I've got a hand at the back there. Seems like someone would like to help me out.
Hmm?
Yes.
You just wanted to ask a question, or?
Yeah, the high-risk mothers, from place to place, depending on the needs, they would reach up to 5%.
Up to 5%. So then how is the actual hemorrhage distributed between the high-risk groups and the low-risk, and the groups that have been triaged to high risk and the groups that have not been identified as high risk prior to?
If you look at the data graphs, there was some kind of baseline. There's still PPH that develops from the low risk group.
Yes.
So there's more PPH coming from the high risk group. What we've done is to now change the protocol to try and check with the whole group. And we did that now that we are looking at the whole group, we're going to cover more of the incidences that were coming from the low group.
Because as you know, in maternity care, low risk can become high risk real fast. Yeah.
Did everyone hear that? Did everyone hear that from the back? Yeah. Thank you. Any further questions from the floor? I actually have one question, if I may, as
Yes.
well. I was really interested to know how you engaged the clinicians into using the protocol. I noticed there was some variability in uptake of the use of the protocol, and a lot of the themes over the forum have been about engagement of patients, engagement of healthcare professionals in change and improvement. And I wondered what strategies you used to sustain use of the protocol and how you engage clinicians in the use of that protocol.
What is happening in our setup is most of the teams that we're working with are already established QI teams, and so most of them are directly working in the labor wards or in the postnatal wards. So it's not been very hard because the establishment was from before. So when we are and the other thing is, before we go into the next learning session and what we're going to be doing differently, we first discuss with them as pre-work to say, how do you look at this and what do you think about it? So I think it's helped us very much.
So by engaging with them at an early stage?
Yes, so at the early stage, and the other thing is we've got a strength because we are constantly using data. We've got a very good data set for most of the facilities. So we're not talking out of context. We are always look at your data, what do you think about it? And everyone had agreed that I think this is a big problem for us and we are overwhelmed, we don't know what to do. So that had given us I think that was the thing that gave us a very big leverage, because everyone was overwhelmed. No, we can't get blood, and so for this one, it was not very difficult because of the need, that the big gap that was already there.
So you identified benefits not just for the patients, but also for the workload and flow of workload for the department and the working levels for the staff as well.
Yes.
Thank you. Do we have any further questions before we close? Thank you all very much for attending this session. We're just coming to an end, bang on time at 3:15. I'd like to thank our speakers very much, Edward, Elie, Caroline and Lizzie, and thank you all for attending the forum. Have a wonderful rest of your stay in Amsterdam, and best wishes for your trips home.